Good afternoon, all. My name is Ozioko Inyemeri, Department of Anatomy, Enugu State University of Science and Technology, Enugu, Nigeria. I want to present a research titled Comparing Facial Characteristics in Orofacial Cleft Patients and Healthy Control. Okay. Orofacial cleft occurs 5th to 12th week intrauterine life. And this occurs as a result of the lack of fusion or partial absence of fusion of the nasomedial and the medial processes. It can also occur as a result of the lack of fusion of the palatal shelves, 5th to 12th week intrauterine life. This is a picture of a baby born with orofacial cleft, and in this case, it is a cleft lip. And this occurs as a result of the lack of fusion of the nasomedial processes. The next picture I'll be showing you is a picture of a baby born with cleft palate. This is another type of orofacial cleft, and this results as a lack of fusion of the palatal shelves. Birth defects are one of the most common causes of infant mortality worldwide. WHO has estimated 240,000 neonatal deaths resulting from birth defects. An additional 170,000 children have been estimated to die before their 5th birthday as a result of birth defects. Orofacial cleft is one of the most common facial birth defects. Orofacial cleft varies in prevalence amongst races and ethnic groups. Several studies have been carried out on cleft around the world, in Nigeria, and most recently in Southeast Nigeria. Okereke et al. Carried out a research and placed the prevalence of orofacial cleft to occur in 1 in every 1,000 child born in Southeast Nigeria. Presently, the most common kind of treatment given to these orofacial cleft patients remains surgical care. The aim of this surgery is to reduce the barest minimum, the very obvious deformity caused by this orofacial cleft. But the problem is that there is lack of objective measures to actually quantify the extent to which this repair should be done. And what we have is the surgical repair being done based on the experience of the surgeon and based on expert opinion. Hence, it is expedient for us to get baseline anthropometric values, which will be used for pre-surgical analysis to actually analyze the cases before the actual surgery is done. This baseline data would also help us to quantify, to a large extent, post-surgical outcomes and to make surgical decisions before the surgery. It is very important. This particular research is very important because in Southeast Nigeria, none of such study has been carried out before to compare the values gotten from this orofacial cleft patients and from normal children. The aim of this research is to develop baseline values for facial measurement in healthy Southeast Nigerian children. This will be used to effect corrective surgeries on orofacial cleft patients. So this is actually a comparative study, and it's carried out in children aged below 5 years, because this is the specific timeline where this corrective surgery is carried out. Study design. For this particular study, we sampled 120 healthy children, apparently healthy children, devoid of congenital anomalies. We took their pictures, and from their pictures, we used the software to get their facial measurements. We also sampled 87 pre-operative orofacial cleft patients who presented for cleft surgeries at the National Orthopedic Hospital, Enugu, and also at the Good Shepherd Hospital, Enugu. We excluded children who had previously undergone any maxillofacial surgery. Ethical approval was obtained from this study, both from the Faculty of Medicine, Enugu State University Science and Technology, and also from the Ethical Clearance Committee of the respective hospitals. Before the pictures were taken, we measured the age of we ascertained the age of the child from the parents and also from their birth certificates when available. We took the weight of the children. We also recorded the sex of the child. And we assigned identification numbers and recorded them in our data pro forma. Now, this identification number was duplicated on self-adhesive stickers, which we adhered to the faces of those children before we took the pictures. That was to avoid errors when taking the measurements. And also, the self-adhesive sticker, we made sure we knew the length of the self-adhesive sticker. And for this particular research, we used a self-adhesive sticker measuring 4.5 cm. This known value we keyed into our images software, and that helped us to convert the values we got to real-life measurements. During image acquisition, we placed the subject 100 cm from the camera. We made use of a Nikon D90 digital single lens reflex camera. We made sure that our camera settings was kept constant all through image acquisition. We made use of a 12.3 megapixel, 600 dpi resolution. We used a fixed focal length of about 90 to 150 millimeter. We made use of a high exposure time greater than 125 milliseconds. And this was to ensure reproducibility. These are some of the pictures taken during data collection. When we had gotten our pictures, we used our images software to get the measurements. We used the SPSS version 23 to statistically analyze our data. And we were also mathematically converted these measurements to indices. Our sample constituted 42% cleft patients and 58% children that had no orofacial anomaly. Table 1 here compares the orbitofascial parameters among cleft patients and our healthy control group. And from this table, we observed statistically significant difference in our face width, face height, middle face height, outer canthal distance, palpebral fissure width, and interpupillary distance. Our face width we measured as a distance between the zygon to the zygon. Our face height we measured as a distance between the nasion to the gnation. Our middle face height we measured as a distance from the glabella to the subnasal. Our outer canthal distance we measured as a distance from the exocantion to exocantion. Our palpebral fissure width we measured as a distance from the endocantion to the exocantion. And the interpupillary distance as the distance between the mid-pupil to the other mid-pupil. From this table, we have observed that our cleft patients have statistically significant shorter face width value, face height value, middle face height value, outer canthal distance, palpebral fissure width, and interpupillary distance. Table 2 here shows comparison of the nasooral parameters, which we got between the cleft children and the apparently healthy control. We observed statistically significant difference in our upper lip length, lower lip length, nasal prominence, length of philtrum, vermilion height of lower lip, length from tip of cupid bow to commissure. We also observed statistically significant difference in our nose height, nose columellar height. When we had gotten these measurements, mathematically we were able to calculate our indices, 10 indices, the facial index, intercanthal index, lip index, vertical mouth height index, upper lip thickness index, our lower lip thickness index, mouth width index, nasal index, and the nasofacial index and nose face width index. We observed statistically significant difference in facial index, lip index, vertical mouth height index, lower lip thickness index, nasal index, and nasofacial index. And this implies that the cleft patients in our cohort had statistically significant higher facial index, lip index, vertical mouth height index, lower lip thickness index, nasal index, compared to our apparently healthy control groups. The objective of every cleft surgery remains to minimize the very obvious deformity that has stigmatized these orofacial cleft patients and made them different from the other normal children. And this is done to achieve, as much as possible, a symmetrically and aesthetically balanced nasolabial region. Hence, evaluation of this cleft deformity is very vital, especially to be able to have a corrective surgery for the facial dimensions of the cleft children to match that of their counterparts within the same ethnic groups. Because study has shown that facial dimensions vary not just within races and countries, but also within ethnic groups. From the present study, we have observed, From the present study, we observed a higher lower face height in our cleft patients compared to our control group. And this is in line with the studies of Horowitz, 1976, and Lizin et al., 2005, though it differs from that of Gocho et al., 2022. The disparity we observed in this our study could be tracked down to the structural, muscular, and skeletal abnormalities that is evident in those cleft patients. In our study, we also observed narrower face width, and this is in line with the study of Duffy et al. 2000. The facial cleft patients in our study also exhibited higher inner canthal distance, and this shows a tendency towards telecanthus, primary telecanthus in this case. And this is in line with the studies of Unweni et al. 2011, also consistent with the findings of Yamado et al. 2002 and AD 2011. The cleft patients in our study had shorter outer canthal distance when compared to the normal subject, and this is in line with the previous findings of other authors. We also found significantly lower palpebral fissure width in the cleft patients in our study, and this has implications for surgery, vision, function, and psychosocial impacts. Similar to our study, Shihiro 2020 and Gosho et al. 2022 also reported vertically shorter face and middle face height in their cleft patients. The use of established indices to objectively measure malocclusion severity in cleft patients has been suggested, and WHO has postulated that an ideal index should have the following criteria. It should be reliable, it should be valid, it should be sensitive, it should be simple to administer. The facial index, the lip index, and the nasal index of cleft patients in our cohort was significantly higher than that of the unaffected age-matched control. And this is consistent with the findings of Ottman et al. 2013. Conclusively, in this study, we found significant differences in the orbitofacial and nasooral parameters between our cleft group and that of our apparently healthy group. We found shorter outer canthal distance, face height, face width, mid-face height, palpebral fissure width, and interpupillary distance of our cleft patients were obviously and statistically significantly shorter than that of the control group. We also observed significant differences in the index. We've discovered longer facial index, longer mouth index, longer nasal index, vertical mouth height index, lower lip thickness index, and nose face width index in our cleft patients. Results from this research can be useful for pre-surgical consultation, surgical planning, post-operative assessment, and also to industries involved in production of orofacial products, such as pigeon feeders, Haberman feeders, nebulizers, and masks concerned for these orofacial cleft patients. Thank you. Thank you. should disconnect.
Yeah, I think so.
Thank you, Prof.
Thank you, Mary, for sticking to time.
Thank you.
So I think we are breaking. Yeah, please.
Yes. Okay, we didn't really do a comparative studies between tribes. We just did a comparative study between the normal children devoid of orofacial anomalies. We recruited them from the nursery schools, creches, and from their homes, of course, with their parents' consent. We took their pictures. We didn't harm them during the course of collection of sample, and we measured their facial dimensions using a software. Then we compared these measurements with the measurements of the orofacial cleft patient. One of our inclusive criteria is that both groups must be from Southeast Nigeria. So for future research, I would recommend that if the resources are there and the time is right, as we have enough time frame, then we can run a comparative study between the various ethnic groups. Yes. Definitely. Thank you, Prof.
We thank all the speakers and the audience. Thank you very much. So we break for lunch now.